we're going to welcome you all to today's session. This is presented by the Community Health Equity and Engagement in Research Team, otherwise known as CHEER. Inclusive Representation, Updated Standards for Maintaining, Collecting, and Presenting Federal Data on Race and Ethnicity. So we're joined by wonderful guest presenters that I will introduce in just a moment. We're first going to get started with a poll. So I will be bringing that up on the screen for you. Yeah, so really eager to hear how aware you might be of the updated categories for race and ethnicity. And there's no right or wrong answers here. Perfect. Okay, so I'm going to share the results. So about 20% of you didn't have a clue. That's why you're here. And that's exactly why you're here. So thank you for joining. Thank you for being curious. And thank you for wanting to learn this information. This is exactly why we hold sessions like this. Close to 75%, so more than about 2/3, heard about it, but cannot recall the updated race ethnicity option. So thank you also for joining to make sure that you can brush up on what those updated terms are and how we can make this the most inclusive approach to collecting race ethnicity. And thank you for the small minority here that are well-versed and ready to implement the updated guidance. We hope by the end of the session, we'll all move towards this. Okay. Looks like we have a few more people coming in, so that's perfect timing because we are just ready to kick things off. So thank you again. This is hosted by CHEER. We are the Community Health Equity and Engagement in Research Team. Our job here at Penn State through our Clinical and Translational Science Institute is to really be a bridge between researchers and community to really ensure that the research that we're doing is very relevant to true community needs and matches those priorities in a way that really can help address health disparities, hopefully with the overall goal of improving health equity and uplifting some of the voices that have really been shunned out of research and the health enterprise as a whole. So that's our goal in CHEER. We really try to advance the inclusion of underrepresented populations and engage them throughout the research process and really give back to the community as well through LAYS dissemination and some of the other work that we're doing. So we do a lot. One of the things that we do love to engage in is these educational sessions to help really fill gaps in some of the work that needs to be done, but we're not really sure how to get started among some of our research teams and our community partners. So hoping to fill this gap of learning to make sure that we can do a better job at inclusion and belonging here across our institution and beyond. I'm joined by my wonderful colleagues, Paula Moody and Jess Schrodold, who will be helping with today's session. And now I'm going to introduce our phenomenal guest speakers today. We have Charleen Hsuan, who is an associate professor in health policy and administration at Penn State. She's also an affiliate law faculty at Penn State Law. She's the lead of our Penn State Clinical and Translational Science Institute Health Policy Core. Her research focuses on how laws influence access to care and disparities in care. Dr. Hsuan is PI on an R01 from the NIH on minority health and health disparities, which examines the Emergency Medical Treatment and Labor Act inadvertently promoting disparities in emergency department transfers. Her first authored research has been published in JAMA Network Open, Health Services Research, Milbank Quarterly, and the Journal of General Internal Medicine. Dr. Hsuan has served on committees commissioned by the Centers for Medicare and Medicaid Services on improving the equity and quality of emergency care. She holds a JD from Columbia Law School, a PhD from UCLA, and a BS from Yale University. So welcome, Charleen. And we're also joined by Dawn Corbett, who's from the National Institutes of Health. She serves there as their Inclusion Policy Officer in the Office of Extramural Research, where she provides leadership and coordination to implement trans NIH efforts to ensure the inclusion of women, members of racial and ethnic minority groups, and individuals across the lifespan in NIH-defined clinical research. Prior to joining OER in 2017, Ms. Corbett held positions at the National Institute of Mental Health for 14 years, where she oversaw program activities to increase diversity, efficiency, and transparency in the mental health clinical research portfolio. Ms. Corbett holds a master's degree in public health from Johns Hopkins Bloomberg School of Public Health and a bachelor's degree in political science from the University of Illinois in Urbana-Champaign. Thank you both so much to our wonderful guest speakers for their incredible expertise in this space. And I know as this session goes on, you are going to learn so much from both of them. Just for some brief logistics, this presentation is being recorded. We do ask that you raise your hand to ask questions during our Q&A session, which we will have designated towards the end. If you have any questions in the meantime, please do pop them in the chat and we'll make sure we address them during that segment. Please do use the chat feature as well to make connections, share resources, and add comments. We certainly want this to be engaging, and we have a lot of folks that are still filtering through, so feel free to introduce yourselves in the chat and where you're here from, what organization you might represent, so we can get to know each other a little bit better. Please do know that the presentation materials will be shared post-session, and that will include a session recording. Live transcription is available and closed captioning is turned on. If you don't need to use this feature, feel free to hide the subtitles by clicking on the live transcript and selecting Hide Subtitle. For our agenda today, we are going to go over the Office for Management and Budget's impetus to make updates to race ethnicity data collection and its impact. And we'll have Charleen present that. Then we'll hear from Dawn on the National Institutes of Health and HHS plan to transition and how this will affect NIH recipients. So I'm sure many of you on the call may be NIH awardees, so we certainly wanted to offer a session to help learn about the process for implementation as this trickles through all of the agencies that we're funded off of. We will have a Q&A and then do a wrap up. So I wanted to first position us as we get into this discussion of why we collect race and ethnicity data. Oftentimes, policies change and we're asked to implement them at the institutional level. And I think it's important that we all take a step back to really reflect on the why. And this is a really important why for why we're updating this guidance and why this, what this means for inclusivity in research. So when we think of advancing the way in which we're collecting race and ethnicity data, this really can help us more succinctly identify health disparities. So we know that different racial and ethnic groups may experience different rates of disease, access to health care, and health outcomes, which can be further revealed by collecting more specific, granular level race and ethnicity data. It can also help us understand social inequities. Race and ethnicity are often linked to social factors, the social drivers of health that many of us are familiar with, like socioeconomic status, education level, and access to resources, which can also influence research findings. This more granular level of race and ethnicity data collection can also help develop targeted interventions. If we understand how these factors impact specific health issues, we can then design interventions that are tailored to meet the needs of these particular groups. A really important feature of this is that it also can help ensure research generalizability, which is ultimately what we're trying to do when we include diverse populations in research. It helps make sure that what we're finding about these groups are applicable to a wider range of people, not just one specific population. And then lastly, it can really aid in policy development. This data could really inform policy decisions to address systemic inequalities and ultimately promote equity. I'm going to now turn it over to Charleen, who will present a policy perspective on updates to the OMB race and ethnicity definition.
Thank you so much, Jen. If you could advance to the next slide. So first, I wanted to thank my co-authors, particularly, and I'll highlight the folk from Penn State, Jeanette Rogowski, Yasmin Mohamed, Amy Young, and the colleagues and Donald Miller as well. And the colleagues outside, Alexis Dabrowski, Eric Way, and Inez Ponce. In addition, we have funding both for NIHD and also NCATS for the CTSI. And the disclaimer is that this is just our the content is just our responsibility. It doesn't represent the views of NIH or WJ, and that the data was produced from data provided by the New York State Department of Health, and that everything I'm going to be talking about is our interpretation of that data. Next slide, please. So Jen mentioned a little bit about the importance of defining race and ethnicity, but I wanted to say a little bit more about why it was that it was really important why there was this impetus to change. So as you mentioned, in order to examine disparities in healthcare, we really need to have a standardized way of measuring and reporting race and ethnicity. And this allows for comparisons between data sources and also permits continuity across time. And the Office of Management and Budget, the OMB, sets standards for reporting and collecting race and ethnicity data for the federal government. In addition, many states and organizations, Jen, if you could go next, thank you. Many states and organizations, including the Joint Commission, follow OMB standards. So, the OMB has important implications for us as researchers if you have an NIH funding, but also is really important outside of that realm. Next slide. So before 2024, the rule was this directive, SPD 15. And this originally was established in the 1970s, and it was revised in 1997 with additional guidelines in 2011. But it essentially established a minimum set of categories for collecting race and ethnicity. And the idea was, if you can, to try to collect race and ethnicity separately. And they also said, if you can, try to provide collect detailed race. But for the most part, a lot of data sources used these broad general categories of American Indian or Alaska Native, AIAN, Asian or Pacific Islander, Black or African American, white or other, and for ethnicity, Hispanic or not of Hispanic origin. Next slide, please. So there were a couple of issues with the old OMB directive, again, SPD 15. So first of all was demographic shifts, right? There have been population shifts across time, and that included, for instance, an increase in individuals identifying as being multiracial. In addition, there were changes in the way that people sort of perceived their own identity. So the Middle East and North African people identified of the origin of Middle East and North African, they were technically classified under white, but this didn't necessarily comport with the way that they self-identified. Patients or individuals who are Hispanic, those who were of origin from Spain did not necessarily always identify themselves as being Hispanic, even though technically under SPD 15, they were considered that. And in addition, some people who were Hispanic would also think that, they would select other race rather than selecting themselves as thinking of race and ethnicity as two separate concepts. They would sort of combine the two. So there has been a whole bunch of research suggesting that these minimum race categories were too broad. Specifically, within race disparities were sometimes broader than between race disparities. So for example, if you would look at instances such as if you look at disparities looking at Asian patients versus white patients, that disparity would sometimes be smaller than disparities between, say, Filipino patients compared to Chinese patients. And so it really emphasized the importance of collecting these more granular information. Can you go to the next slide, please? So starting in 2022, the federal government convened a working group of career staff to discuss possible changes to SPD 15. They engaged in a whole bunch of different listening sessions and information gathering. And in January of 2023, they published a notice in the Federal Register on initial proposals to update this SPD 15. And I copied here, I don't know if folk are familiar with the Federal Register, but it is an extremely some of these publications can be extremely detailed, and the different agencies, if they're coming up with potential new rules, potential new regulations, they will sometimes publish what are called notice and requests for comments. And so this one, which was relatively short, it's about 10 pages long. It describes, what the sorry, if you can go to the next slide, please. It includes what the rationale for the change is, what they propose, and what is unknown or what they would like more information on. Next. So, for instance, they had this potential at the time, figure, which was saying, this is what we'd like to ask. Can you provide details about comments about this? And so they would ask a whole bunch of questions, such as, is the current default structure of this recommendation appropriate? Should it pursue a more voluntary approach to the collection of disaggregated data, as opposed to having a default of collecting such data unless certain conditions are met? Next slide, please. So I'm gonna take a step back, because this is all happening in parallel to the grant that Jen had mentioned that we had, which was looking at racial and ethnic disparities in emergency department transfers. And when we were working on that project, we get hospital discharge data from several states, including New York, and New York hospital data contained very detailed information about race and ethnicity. And we were in the midst of trying to code race and ethnicity so the categories are meaningful for research. While we were in that process, the notice for comment came out, which is when we got very interested, because in our data, we have very detailed information about race and ethnicity. So New York hospital data uses the CDC's race and ethnicity code set, where you have almost 1,000 different categories for race, and then additional categories for ethnicity. And we were interested in, next slide, please. So what we did was we used the data that we had from this New York State hospital data, and we tried to answer some of the questions that were asked in the OMB request for information. So specifically, some of the questions that they asked were, what are the benefits and burdens of collecting more granular data? What's the appropriateness of it? What's the benefits of asking for detailed race and ethnicity data to be submitted by default? Are there different sort of collection or tabulation options, and whether current minimum categories were sufficient? So what we did was we basically used the discharge data that we had to help provide information, including the fact that large percentages of Asian NHPI patients provided detailed race information, and that differences within our data suggested the importance of having these types of differences, as well as different patterns of changing race and ethnicity across time. Our comment was one of over 20,000 comments. So there were many comments that were written about this. And of course, being good researchers, we had done all this data and we want to have a publication out of it. And so what we have done is, what we did was create a manuscript. And the framing of the manuscript is slightly different from the framing of the comment, although a lot of the information that was in the comment, some of it overlaps. So in addition to OMB, multiple states require state agency to disaggregate race and ethnicity to provide more detailed information. And since 2014, New York State encouraged state licensed hospitals collect detailed race information for Asian NHPI patients and detailed ethnicity information for Hispanic patients. So the research question we were asking is, when policies support the collection of detailed race and ethnicity information, do hospitals actually collect this information, and do patients actually provide it? And we did a descriptive analysis of this. Next slide, please. So this is the percentage of patients, percentage of visits where there was detailed race. And you can see the big difference between Hispanic, Asian, and HPI, the first three bars, compared to American Indian or Alaska Native, Black or African American, and then white, which, the bars are barely there. You can't even really see them. Next slide, please. We were interested in finding out, well, why is it that that some hospitals are collecting information about detailed race information, but not others. And so we started digging deeper, and what we did was we looked at maps of the demographic makeup of the counties where hospitals are reporting detailed race. And you can see here, like the size of the dots show, the bigger the dots, the more patients that provided detailed race information. And then the shading shows the heavier the shading, the more the county had either Hispanic or Asian population. We had similar graphs also for NHPI patients. Next slide, please. And what we had found was that about 70% of hospitals were collecting information about Asian, NHPI, or Hispanic, but they were not necessarily in the areas where geographic regions where the greatest populations were. Instead, it seemed like, next slide, please. It seemed like the biggest drivers were that hospitals were collecting detailed information if they were bigger in more urban areas, and also in communities with lower social vulnerability or area deprivation index. So in other words, these are wealthier hospitals in wealthier areas. However, because these are the larger hospitals, even though only about 70% of hospitals are collecting detailed race for instance, Asian, 92% of visit responses are in hospitals that collected this information. So most of the patients are actually getting covered, even though not all hospitals are collecting this data. Next slide, please. So while we were working on the manuscript, the final OMB rule came out, and I know that Dawn is going to talk more about this, so I won't go through the details. But it was an interesting process because we had to modify our manuscript sort of midstream a little bit because we wanted to make it as relevant as possible. Next slide, please. So one of the things that we started to look at was this last point on the slide, which is that the detailed races, the specific detailed races that are the default, were not 100% match for the that they were not a match for what our data showed as the most prevalent detailed races. And so it suggests that organizations, if they're collecting this data, should try to tailor perhaps in addition to having the 6 that are in the OMB final rule, they may also want to tailor their own data collection so that it's specific to their populations. And then the overarching takeaway point is just that that the New York State policy encouraging collection of detailed race and ethnicity information is probably effective, and that it may be driven less by community factors and more by hospital level factors, and that it's primarily larger urban hospitals that are better resourced. Next slide, please. So just we do have a bunch of limitations, which because of time, I'm not going to go through, except we're aware of them. Next slide. Thank you very much.
Thank you so much, Charleen. It's amazing the work that you did to support, the tailoring of this at the institutional level. I think that's really important as we think of implementation here. What are some of our local populations that we see that migrate, even as we're doing data collection in central Pennsylvania or across our Commonwealth, that could be added to this guidance. But I think, at the very least, making sure that these more inclusive options are provided, knowing that there are certainly some resource limitations, but hopefully if we do a lot of education and have systems in place to implement the collection of this at the institutional level, that hopefully uptake will be greater. Thank you so much again, Charleen. I'm going to now pass it over to Dawn to share an update on NIH race and ethnicity data collection and use.
Thanks, Jennifer. So hi, everyone. I'm Dawn Corbett. I'm the Inclusion Policy Officer in the NIH Office of Extramural Research. And as Jennifer mentioned, I'm going to talk to you about what these changes in the OMB categories mean for NIH. Next slide, please. So just a refresher on what we're talking about when I talk about SPD 15. I'm talking about the Office of Management and Budget Statistical Policy Directive number 15, which are the OMB standards for maintaining, collecting, and presenting federal data on race and ethnicity. And as Charleen touched on, the goals of this directive are to make sure that we have comparable race and ethnicity data across federal agencies so that we are able to compare federal data sets. And we also want to maximize the quality of the data. So we try to make sure that the format, the language, the way that we're collecting the data is the same across the entire federal government. Next slide, please. So the specifics of the changes were announced by the Office of Management and Budget on March 28th of this year. And the last change to this directive was actually in 1997. So it had been quite a while since OMB had updated the race and ethnicity categories. They've only done that twice, actually, since the categories have existed. And so the biggest changes are, the first is that we're going to collect race and ethnicity information using one combined question. So currently, if you're collecting this information according to NIH standards, you ask two different questions. Are you Hispanic or Latino as an ethnicity question, and then all of the races with which a person identifies. This will now be combined into one question for all races and ethnicities. As was mentioned, there's also an addition of a Middle Eastern or North African category as a new minimum category. This was previously under white, and the requirement for the collection of detailed race and ethnicity categories by default. Next slide, please. So in terms of what this looks like, what you can see there on the left, these are the 1997 categories that are currently used by NIH, and most federal agencies are still using this because this announcement was fairly recent. Which asks, are you Hispanic or Latino, yes or no, and what is your race? And you select one or more of those racial categories. With the changes, as you can see, as was discussed, we see the new Middle Eastern or North African category. There also was a change in terminology. So Native Hawaiian or other Pacific Islander is now Native Hawaiian or Pacific Islander. And all the racial and ethnic categories are all under one column. Instead of two separate questions, there's one. And then one of the biggest changes is that there are detailed categories for every racial or ethnic category listed and a write-in option for each one. So quite a bit of more granular data that is to be collected with the new categories. Next slide, please. So what needs to be changed? So the directive applies to all federal information collections. So this includes the census, this includes things like our CDC, National Health Surveys, our SAMHSA surveys, all the administrative forms across the entire federal government need to be changed to adhere to the new SPD 15 whenever we're collecting race and ethnicity information. This applies to public information, it applies to internal information. It really is quite a bit across the federal government. Next slide, please. So these are just some examples of our public-facing data collection across NIH where we collect race and ethnicity data. There's quite a bit more, but these are some you may have interacted with. The first is the ERA Commons personal profile, where principal investigators will go in and enter their demographic information. We also have clinicaltrials.gov information, collects baseline characteristics that include race and ethnicity. In the middle there is the Inclusion Enrollment Report, which my office oversees, where we collect race and ethnicity data for participants in clinical research, and a trainee diversity report, which collects the race and ethnicity data of trainees. So just looking at this example, we have 5 different forms, 5 different systems. These touch thousands and thousands of researchers, which will need to be changed. In addition, we also have, IC repositories. So if you get funding from a certain IC, you may submit data to a repository that they support. Those will also need to be changed, federal human resources data collection, et cetera. So the breadth is quite large. And this is quite a lot of work that's going to be happening across NIH over the next few years. If we go to the next slide, we can see some of the other considerations that we're thinking about. So one thing that we are very attuned to at NIH is that these data have many dependencies, right? So we can create a system with new race and ethnicity categories. But the question is, can you provide this information in the way that we're requesting it? And so one of the things that eventually would also need to change are the NIH grantee and recipient data collection. So if you receive NIH funding, you will need to change the way that you're asking race and ethnicity information in order to provide it to us in the required format. We also recognize that you may not have complete control over your data collection. Many of you are using secondary data sources, such as electronic health records, repositories, registries, national surveys, claims data, insurance data, surveillance systems, administrative records, vital records, right? So all of this has to be changed too in order to make this change happen. And we do recognize across HHS that in order to provide data to us in this format, we also need to make sure that data sources have this data as well. So if we move to the next slide, I want to talk a little bit about the timeline. So as I mentioned, we recognize, given that there are many dependencies in these changes, and it's also quite a lot of changes for NIH to implement as well, that OMB did give us 5 years to fully implement these new categories across the federal government. You may be seeing changes to different data collections at different time points. Not everything's going to switch at the end of these 5 years. But the timeline starts with the issuance of the OMB guidance, which was on March 28th of this year. And in the guidance, they gave federal agencies 18 months to develop federal action plans. So at NIH, our action plan is being developed by the Department of Health and Human Services. We're working very closely with them to coordinate across HHS. And their action plan is due on September 28th, 2025. And that action plan will be made public. And then after that, we have until 5 years after the date of the announcement, which is March 28th, 2029, to fully implement. So that's the federal agency deadline across all the federal government. All of our race and ethnicity data collection needs to be changed by that March 28th, 2029 date. So I think a takeaway here is the changes are not immediate. It is going to take some time to change all of these things across the federal government, but you will be seeing changes to different data collection across the federal government over the next 5 years. Right. Next slide, please.
All right. Hannah, I'm making a bagel now. Sorry, I was just doing something.
Okay, so in terms of the transition process and what that looks like in HHS, HHS, this process is coordinated by the evaluation officer. That person is within the Assistant Secretary for Planning and Evaluation. That's Dr. Susan Jenkins, who leads our Office on Evidence Evaluation and Policy. So she's coordinating the development of this cross HHS action plan. And she's doing that in partnership with the HHS statistical officials, who is also the director of the National Center for Health Statistics. So HHS is coordinating with all of our optives to create this action plan. As I mentioned, there aren't any changes yet. And I think, if there's one takeaway that you get from this, is that NIH has not made any changes at this point to its race and ethnicity data collection. So if you are an NIH grantee or recipient, or you're submitting an application, you should continue to follow the instructions in the NIH application guide and the RPPR. And those instructions currently reflect the 1997 categories. That doesn't mean that you can't go ahead and change your data collection, but one thing to keep in mind is until NIH makes changes, you will need to continue to report that information to us using the 1997 categories. And we will give you notice in advance if there are any changes to race and ethnicity data collection. As a matter of course, we make any announcements about changes to NIH policy in the NIH Guide for Grants and Contracts. So you could expect to see a guide notice there if there are any changes to those requirements. But as of yet, we've not made those. You can expect to see more information about when we might make those in the HHS action plan when it goes public next September. Next slide, please. I also want to point out some resources that are available to you as you're thinking about your data collections and how you might transition them to the new format. There's a nice website that the Office of Management and Budget put together. It's spd15revision.gov, and this includes a lot of resources like the 2024 Federal Register Notice. Some things that I find helpful are the bridging data tools that are available. There's also some FAQs and the work groups report. So if you're curious and want more information about these categories and how you might implement them, I think this is a great place to start. Next slide, please. In addition, HHS is working on revising its implementation guidance. So it has a very informative website with guidance on data collection standards for race, ethnicity, sex, primary language, and disability status. This website was updated after the OMB announced the changes to the categories, so it does reflect those changes and HHS efforts to implement those changes. So this is another place where you can look to get information if you're thinking about how you might code information going forward. As I mentioned at NIH, we haven't made any announcements about what this will look like. I think you can expect detailed guidance when we do update race and ethnicity categories. But one place to get an idea of what that might look like is looking at the guidance that's provided by OMB and HHS, as we are looking to coordinate across federal agencies to make sure that we can accept information from CDC surveys, for example, or from electronic health records. So you can expect a very similar approach across the federal agencies in terms of implementation. Next slide. Thank you. All right, so anyway, I want to thank you all, and we'll turn this back over to Jennifer for Q&A.
Thank you so much, Dawn. That was so helpful for us to sort of have a sense of, I think a lot of us were wondering what the timeline looked like. So hopefully for those that have attended today that are NIH funded, you have a sense of when this will take place. And I appreciate, Dawn, your point of not necessarily waiting for, all of the federal agencies to catch up with the implementation. It's a lot of work, I'm sure, from an IT perspective and all the different systems, but it doesn't mean that we can't implement that at a more local or institutional level in terms of advancing the inclusion of the way we ask race and ethnicity. So I encourage everyone to take what they learned today to implement it in their research as they're able to. And before we close today, I'll be providing more information on how we've made it a little bit easier for you to do that. But keeping in mind that these things do take time when they're so the scale of the implications across all of these federal agencies, it does take time to implement. I want to now save some time for some questions that you might have for Charleen, Dawn, or the CEnR team, and we are happy to field those. Looks like we have one question in the chat. What is the reason to combine ethnicity with race? When ethnicity is combined, it is common for Hispanics to not add their race. How can this be prevented when the two questions are combined? That's a great question from Gabby.
I guess I'm happy to take a stab at that. My understanding is with the 1997 categories, there was a move to separate the questions of ethnicity and race and to ask those as two separate questions. One thing we saw pretty consistently in our data is we had a high proportion of participants who identified as Hispanic or Latino who did not select any racial category. And so we would see them in unknown race. Now, depending on how you're doing your analysis, you may just throw out those who do not identify a race, right? And so it actually may result in less data, about the Hispanic or Latino population rather than more data, and I don't think that was the intent. And so with the new way that we're asking the information, you simply identify all the races and ethnicities with which you identify. So if you just identify as Hispanic or Latino, that's okay. You don't have to select another race or ethnicity, and you won't have an unknown race. You'll just identify as Hispanic or Latino. So that would be the difference going forward.
Great explanation. Thank you, Dawn. Any other questions? Feel free to speak up or pop it in the chat. Okay. How do recommendations for reporting by multiracial participants change based on combining these?
If we can go back actually to the slide with the detailed categories, that might help people kind of visualize this as we go forward. So when you're asking the question about what is your race and ethnicity, you will ask them to select all that apply. So if you identify as more than one race or ethnicity, OMB has advised us that there will be a new category of multiracial and or multi-ethnic. So you may have seen this on the census as some other race. At NIH, we currently collect a category of more than one race. You could expect that to transition to this new category of multiracial and or multi-ethnic. And I think OMB's goal is we will collect more detailed information about those individuals who are multiracial or multi-ethnic in terms of which specific races and ethnicities they identify as. And so in terms of a recommendation, I would say I think OMB would like you to retain as much information as possible about those individual categories rather than simply kind of lumping them into the multiracial, multi-ethnic category. Also including information about those specific categories. And there's some more guidance. If you look at that website that I recommended, they talk about how that can be reported. So example, you may see white alone and white in combination, and Asian alone and Asian in combination. So there's a lot of good information about how that could be combined.
Great question, Hannah, and great response, Dawn. A few more questions. Is it required to select a more detailed category? For example, if someone doesn't know their more detailed ethnicity? That's a great question, Emily, one I was going to pose. So we'll start with that one.
So I can say my understanding of the guidance currently is that OMB expects us to present the detailed categories for everyone, and that there is not an option not to identify. However, people can always not check a box. We are seeking some clarification from OMB in terms of exactly, what that means. So I don't have a definitive answer on that because I think there have been some questions coming up about making sure that information is voluntary. So people can always not check a box, but I think one question is, can there be a box that says, I don't identify with any of these detailed categories? And I don't think we have guidance on that yet.
Interesting. Okay. And the second piece of this was, in terms of NIH-funded studies, will there be any consideration for small sample sizes where someone reporting their detailed race ethnicity might be potentially identifying?
Yeah, this is definitely something that we're talking about internally right now, because I think one thing that's paramount is that we protect the privacy of the people from whom we're collecting data. And we certainly don't want to have any information that could jeopardize that. I can say in general, the way that we do collect data on individual participants is very secure. All of our data are encrypted. There are very few individuals who have access to individual level data. I don't. It's really just the IT staff who may be able to access that information. So, but that's a very valid concern. And I think that's something that you can expect to be addressed when we put out guidance.
Perfect. Another comment, a few study participants have raised the issue that when they see such a long race list, they are not willing to answer race. Is that something that we can expect, and how can we mitigate that?
I think that's great. That's great feedback. And I think we've heard some similar feedback. What I can say is that OMB is still very much working on implementation of this. And I think that we are very open to hearing these kinds of things as we work out implementation. You can expect HHS to kind of be reaching out to some groups, doing listening sessions and such. And I think this kind of feedback is very important for us to hear as we think about, how you all are going to implement this.
And can I just weigh in here? So I think I had mentioned that the sort of data collection process for the state of New York, the categories are actually even more detailed than what the OMB suggestion is. So for the OMB, it's 6 categories for each of the sort of major race groups. And in the CDC guidelines, there could have been, it was trying to be as inclusive as possible. So like I said, there were about 1,000 of them that you could have implemented. And it's a little bit different because the hospitals were the ones that were deciding which ones to implement and how they wanted to do that. But it is interesting that in our data, we did find that about 40%, 40 to 60% of patients were actually selecting the more detailed race. So you're right. We might be losing some people that we don't, and we're not necessarily aware of who we're losing, but it is a substantial proportion are actually responding with their detailed race.
It's really helpful. One question I had was the delivery. So does it matter? And I'm thinking of, some other, like the Prepare tool, for example, those that are familiar on the health system side, that's collected to get at social drivers of health and some insecurities around social services. So, the implementation of how that tool was validated was so that it would be self-reported by the patient themselves completing the form. So in terms of implementation for this new guidance, of course, some of our studies that are secondary data analysis that are relying on, EHR or other data sources, wouldn't have this opportunity. But in like the gold standard perfect world, would we advise the participants to fill this out themselves, or are we asking this and then filling it out for them? Like, what's the best way to implement it to capture the most transparent and honest like responses?
So I can say from the NIH perspective, we expect the data collection, of course, to always be voluntary, and we expect it to be based on self-report. There are a few exceptions to this when the participant is unable to provide the information. So for example, we may have some data collection happening in emergency rooms where the participant is unconscious and can't provide the information. But I think, the evidence shows that the correlation between one's self-reported race and ethnicity and perceived race and ethnicity is not great. We want this information to be from the participants themselves based on how they identify. So in your data collection, you should be asking the participants the question and asking them to provide that information to you rather than making assumptions about race and ethnicity.
Great. Any other questions from the group? Are there concerns that these new guidelines will blur the lines between race and ethnicity and the ways that the public or how others interpret the origins of race, ethnic disparities?
Yeah, I think that's an interesting question. There's a lot of work at NIH about the conflation of race, ethnicity, and other variables. So one concern is genealogical ancestry, right? And I think that can be hard to communicate to participants, that we're not asking about your genealogical ancestry. We're asking about how you as an individual identify and genetic ancestry, right? So I think at NIH, our push is to be very specific and deliberate in our language. And I think this is something that we have work to do in educating not only the research community, but also the participant community on what are we really asking for. Because yes, I do have concern that people will blur different concepts. But I think the important thing to keep in mind is this should be based on self-identification. This is a social construct. We're not asking about a person's family history. We're not asking about their biology. We're simply asking about how they identify. And I think we'll have to keep making that point as we transition to these categories.
Do we know if this has been peer reviewed by the lay community? Like who came together to form this OMB guidance, and was there external review by various community partners that are, you know, that could reflect on these categories?
Yeah, so this was a very extensive process by the Office of Management and Budget. They had a number of listening sessions with the general public. They also received many thousands of public comments, which were taken into consideration. So there were a number of advocacy groups that participated and provided comments. And they also went to the federal agencies. And so they asked us for our input and what we felt about implementation. So there was a lot of feedback. And I think that's one of the reasons why OMB coordinates this across the federal government. I think because of the sensitivity of this issue, we want to make sure that there is a space for people to make those comments. So yeah, that's there. But I agree with, you know, Gabby's comment in terms of blurring the concepts. We don't consider race to be a biological variable or to be genetic. We consider genetic ancestry to be distinct at NIH. We consider both race and ethnicity to be social constructs. But ethnicity in terms of how we define it is more based on an individual's culture and language and other variables. So we do have definitions on our website that are a little bit different, but they may be helpful.
And to that end, our team has worked within our CTSI to develop some templated language that I'm happy to share out, and of course, room for feedback from everyone on this call and our entire listserv related to the why we collect this data. So not just specific to race and ethnicity, but also sexual orientation, gender identity, and some other variables that are very important for us to further address health disparities. So some language around the why we have developed, but totally open to this group's expertise for some more fine tuning of that and refining to be as responsive as possible to have folks complete this in a way that makes sense to them. So I'll be sure that that's shared out with our communication. Okay, I don't know if we have any other thoughts or questions. Have them continue to filter in, and we'll make sure that they continue to be responded to even post-session if we need to. I just wanted to share that what CEnR is going to also be working on as more guidance comes out through NIH. So Dawn, we'll certainly stay in touch, and Charleen as well, with the wonderful work that you're doing to see how we can tailor the uptake across Penn State and to some of our wonderful external partners that are on our call today. What we'd like to do to make this very tangible is to create a REDCap data dictionary that we can share broadly for all of you to swiftly implement in your projects if you use REDCap, or have, you know, a Word document at least of the different options. So this would be sort of the gold standard through OMB's eyes, but maybe some more direction as more data gets published from Charleen's team and what they're finding. And really the idea of tailoring it at the more local level to the different underrepresented populations that exist that we're engaging in research opportunities. So that's something that's definitely on our radar. We want to be sort of filling in the gaps of implementation, and we know that you need not only the guidance, but the sort of the keys to success for how to implement that. So that's something that will be on our radar to share broadly across with all of you. Any other questions?
Jen, can I make a plug for, so if anyone is interested in getting more involved with the policy process, so for instance, you know, responding to a notice for comment, you are welcome to submit a CTSI consultation for health policy impact. And I'm putting that in the chat right now. And I am happy to meet with you and discuss.
Thank you so much, Charleen, for doing that. I'm going to be launching here a closing poll. To just get a sense of how likely you might be to include these updated categories in your research. So I think we hit our mark in terms of at least raising awareness, and it's okay, you know, for those that are somewhat likely, maybe not 100% sure, because we don't really know what implementation might be for your particular research needs. So totally okay. Let us know what gaps you have, and you know, again, we're here to help fill those for you. Looks like we have from Dawn. Thank you so much for sharing that notice in the chat. So please do check that out. I'll make sure all the links that were shared in the chat are also included in the follow-up information that we send out. There were several links within the PowerPoint that were shared as well. So we'll make sure that those are hyperlinked for you to easily access. And I will again include that templated language around the why behind collecting some of these important demographic information. Paula also did put in the chat a short and sweet evaluation. We do ask that you complete that so we can learn about the utility of these educational sessions and make sure that we're continuing to meet your needs as learners. I want to thank you all on behalf of the CEnR team for joining. I wish you all a beautiful holiday season. I hope it's a time of rest and reflection, and you know, can store up some energy to get through the next year and beyond. So thank you so much for joining. Appreciate you all. Take care.